Hi, everyone. Welcome. Thank you for joining us today for the National Hispanic Medical Association's Medical School Roundtable, discussing careers in HIV treatment. My name is Denise Nemeth, and I will be your moderator today. The National Hispanic Medical Association is a nonprofit association representing the nearly 50,000 licensed Hispanic physicians across the United States. NHMI's mission is to empower Hispanic physicians to lead efforts to improve the health of Hispanic and other underserved populations. NHME has partnered with the Center for Disease Control's Let's Stop HIV Together campaign to bring you educational content on careers to explore infectious disease work, improving the health outcomes of those in our community. Currently, I am a fourth-year medical student at UIW in San Antonio, Texas, and I will be applying to general surgery residency upcoming September for Match 2025. I am an aspiring rural surgeon, and I am considering a career in surgical oncology. I'm originally from Piedras Negras, Coahuila. I grew up on the border of the U.S. and Mexico, and I used to be a PA. I did general surgery and vascular surgery in that area. I became very involved with HIV care. I think that as a medical community, we strive to destigmatize HIV care, but we need to start with us, with doctors, with nurse practitioners, with everyone involved in the care that we provide people with HIV and with HIV prevention efforts. And so I really took it to heart, and I became very involved in trying to get educated and provide education to others as well. I am a strong advocate for Latino health, and I hope to see increased representation via increased numbers of Latino and Hispanic physicians and surgeons. And I am very happy to be here moderating today. Today, we are joined by our very own Dr. Sara Hurtado. She is the 2022 HIV Medical Association Research Award winner and Associate Professor in Infectious Disease at the University of Nebraska Medical Center. I would also like to introduce to you Dr. Yury Parra, Medical Director at Upper AIDS Ministry Harlem United, who focuses on providing comprehensive primary and HIV care with sensitivity and cultural humility. And last but certainly not least, I would like to introduce to you Dr. Gina Osorio, Infectious Disease Specialist in the City of New York and Program Director in Icahn School of Medicine at Mount Sinai Morningside, Mount Sinai West, and Mount Sinai Beth Israel Infectious Disease Fellowship. Welcome. And I would love to open the floor to them so that they can tell us a little bit about themselves and what drove them to HIV care. I would love to start with Dr. Gina Osorio.
Hello, everybody. A little bit about myself. So I was born in Guadalajara, Jalisco, Mexico. So I but came to the U.S. when I was 3 in Corpus Christi, Texas. So I grew up in South Texas. Say after many venues, Tejana is what I would say. I trained at Baylor for medical school and residency in Houston, Texas, where there I saw people basically in the early 2000s living longer with HIV and really liked the idea that you were an internist. Did my MPH at Mailman, Columbia, and that's how I left Texas to New York, and did my infectious disease fellowship at University of California, San Diego, and then came back to New York, and I've been here for now 14 years, and a little bit about myself, and grew up uninsured in Texas, and that's one of the reasons I went to do my MPH at Mailman, just to understand why the healthcare system was the way it was back in 2005 is when I left at that time. So a little bit, and that's
I love a fellow Tejana on the panel. And thank you so much, Dr. Osorio. Dr. Hurtado, we would love to hear about your story.
Sure. Yeah. Good to be here. Thanks for having me. So I was born in Mexico City in Ciudad de Mexico, and I grew up there for the first few years of my life and then moved to New York City. I actually lived in the Bronx and Manhattan, and grew up with a single mom who was a nurse at Montefiore in the Bronx, and so I got interested in healthcare early on, just watching my mom really her passion for her job. And but I come from a family of teachers and ministers and a lot of sort of public service, and always wanted to work in public health as well. So then, and ultimately ended up staying in the New York area and went to medical school at Mount Sinai. And Mount Sinai is right on is unique. The main campus, the medical school, is on the border of the wealthiest zip code in the country, and then some of the most impoverished zip codes in the country. And so I saw firsthand real health disparities, and was impressed by how many of health disparities were driven by infectious diseases. And so was really inspired to go into infectious diseases through that route, and ultimately ended up in the field of HIV. And I love my job. I get to do a mix of primary care and inpatient care and research and medical education. And so, and we really, just like Dr. Osorio was saying, we really do get to see people make a true difference. One of the most rewarding things is seeing somebody go from being, very, very sick to better within 6 months with effective treatment. And so it's a really rewarding field to be in. But that never happens without multidisciplinary care, support, resources. So you get to be aware of all of those things along the way.
Right. Thank you so much for sharing that. That's a very interesting path with you being exposed to, being in that area with, the wealthiest of the wealthiest, and, the most underserved. And so I really love also what you said about, like, it's so fulfilling to see someone that's so ill, and with effective care and with the right resources, you can just impact them. And that applies to so many pathologies, right? And we would love to hear from Dr. Parra. Dr. Parra, if you could share a little bit about your route and your path to your work in HIV care, we would love to hear about it.
Yes, good afternoon. I'm very excited to be this panel and also hear the narratives of my fellow panelists. I do see a theme. So similarly to them, I was born in Colombia, and I came to New York City in middle school. And I also experienced with my family the struggles of navigating a healthcare system, and received most of my care through a federally qualified health center, which certainly impacted my decisions later on in my career. I went to medical school in Chicago at University of Illinois, Chicago, and I was part of the urban medicine track. And this is where I started to set the foundations that certainly the medicine is fascinating, and I was challenged to be the best clinician I could be, but also recognizing that the sort of science and medicine alone is not enough, that really understanding the complexity of the factors, what are the social factors that affect the health of someone, what are the social barriers, what is the social racism. So early on, I really wanted to combine my career with social issues, policy, and advocacy. And that is the reason why I decided to do family medicine. And I particularly chose programs that had a strong curriculum in underserved medicine, policy, and advocacy. And that's how I ended in Jefferson, at Thomas Jefferson, in the underserved care track. And I love all the parts of family medicine, the women's health, the adult medicine, the pediatrics. And I realized that I was always going towards, like, okay, what are the systems? What are the social issues? What are the policies? And when third year was coming along, I was like, I don't think I want to practice medicine right yet. And this is when the opportunity to do HIV medicine as a family medicine physician through the HIV-MA fellowship came up. So I was like, oh, that's perfect, because I have an opportunity to continue to span on a field that I'm interested in, which is HIV medicine, Hep C, substance use disorder, but also do more policy and health systems. And so I hope to bring to this conversation, a different way to do HIV medicine through sort of non-traditional systems, and recognizing, as the prior panelist said, we need the support from multiple fields, right? It's interdisciplinary and it's advocacy, and so that we can talk about prevention, but also really understand what are the factors that put some communities at a higher risk and exposure than others. And I think that is an essence to the work that we all do and are very passionate about.
I couldn't agree more. So this panel is basically focused a lot on HIV education and why why it's needed in all aspects of treatment, what kind of efforts that can be undertaken. I think, like in my experience when I was practicing in a medically underserved area as a PA, I realized like there's an opportunity in every single point of care that patients encounter. A lot of people would come to me and they would be like, well, you do surgery. Why are you so interested in HIV? And to me, it's like, that's an opportunity for me to do prevention. It's an opportunity for me to contribute to the health of that patient, even if it's not a surgical kind of pathology. For me, it was a way to contribute to the health of my community. I think like public health is everyone's responsibility, especially as physicians. It doesn't matter what field you're in, it is your responsibility. You have to contribute to it. You have to be very aware of it. And so the more education we can get and the more education we can put out there, the better. And so I would really love to start by asking a couple of questions and getting this roundtable started to, talk a little bit about this. So we're going to start about community engagement. I would like to ask Dr. Hurtado, what roles do community engagement and service learning play in medical education regarding HIV/AIDS awareness and prevention?
Apologize, I'm getting a call, but okay, it's stopped.
Oh, it's okay.
I don't have a way to silence my desk phone. So I was getting nervous.
Essentially the question is, like in what role does community engagement serve in medical education regarding HIV and AIDS awareness?
Yeah, so I think community engagement is essential. So much of medical education is within, I guess many of us would call it the ivory tower, where we're sitting in a classroom for many hours of a day, listening to lectures. We do get the ultimate in sort of applied learning once we get to the wards, but much of that is also in academic institutions and less in the community. I think more and more medical schools are trying to get out into the community, but I think sort of the best way to really expose students to the field of HIV prevention and that happens outside of the walls, because by the time they get into the medical system, it's already often too late. That's when we unfortunately diagnose people with very advanced HIV, or are offering post-exposure prophylaxis, but don't have the opportunity to prevent. And so getting students the opportunities to work with federally qualified health centers or advocacy groups where they can see the efforts and see how things are organized and really talk to patients. Because I think one thing students don't realize is that from day one of medical school, they already have skills that can be applied in the community. And so getting them out there practicing, just talking to patients is such an important skill. And so I think that's one way. I think another way that we've discovered of getting students engaged in the community is sometimes it's hard with the medical school class of 130 students to find opportunities for everyone to volunteer with an advocacy group or work with a public health clinic or a federally qualified health center. There aren't always spots, but one thing that I found really effective that also helps them engage with the community is to bring the patients to them. And so in our first year microbiology curriculum, we spend a day talking about HIV natural history and pathogenesis, and the students are always, slightly interested in it, but then we bring a panel of patients that day. And so we ask usually 4 to 5 patients who are open with their HIV status and feel comfortable talking in front of a group of students. And it's probably the most impactful, the most well-rated event of the whole, 6-week block, because first-year medical students are so hungry to actually have involvement in patient care. Why are we learning all of this basic science again? How is it really going to apply? But they finally get to meet patients, hear their stories. I think it helps erase a lot of the stigma. Some people might have ideas about what somebody with HIV looks like. And so we try to bring a real diverse group of patients so that people can see that HIV doesn't look like any one thing. Everybody's story is different and everybody needs to be listened to. And I think they just learn in that one session a lot of empathy and a lot of real take-home messages, like how to deliver a diagnosis well and how to do so poorly, just from the patient's stories. And so I think that helps them engage with a community in a way that's a little bit sometimes more feasible on a large scale.
That's so beautiful. I think like medical humanity is so important, humanizing disease processes and remembering like these are real people, like everyone that we're treating. I think it's very important. Dr. Parra, did you have something to add?
I wanted to say as like for the medical students or pre-medical students, as you are looking to opportunities, some of them would happen before through internships, through volunteering. Sign up for listservs, like, sign up for the listserv so that you're aware of what's happening. So there is, through CDC, through the HIV campaign, there are multiple listservs to sign up. And in medical school, there is now a number of tracks. We would hope that this is not an isolated track that all the medical students can have exposure, but there are tracks on like refugee health, there are tracks in underserved medicine. So like at UIC, I was part of the urban medicine program, and there are medical schools that have that, and also advocacy groups. I was part of AMSA, and there are two, and there's like a lot of advocacy. And so certainly find that community, like register for conferences, like just get exposed, especially that first summer between first and second year. I was like, wait, hold on, that's when you get a break, right? I was like, I forget when you get a full summer. So certainly seek out those opportunities just to be exposed. It will make you a stronger clinician if you really understand systems, community, and advocacy. The medicine will come, but certainly that will be an important exposure.
Absolutely. It really makes you pick up these skills that otherwise you won't be able to learn. You can't just learn them in a classroom. And I think what Dr. Hurtado also said was, I think as a medical student, sometimes you think you don't have skills because you're just starting, but you already have a set of skills that's valuable, and that you have to remind yourself that you are valuable and that you do have something to bring to the table, even if you're a first year or a second year, whatever year in training you are, just to remind yourself, because it's easy to lose sight of that, right? I think with medical education. So thank you so much for you guys' input. Dr. Osorio, I would love to ask you how do you manage common infections associated with HIV and AIDS in a clinical practice setting? And I kind of want to open this to everybody, but let's start with Dr. Osorio, and maybe we can move to Dr. Parra, since you guys have a little bit of different practice settings.
Well, I wanted to answer the question about community engagement at first because it is a passion of mine, and it's one, coming from South Texas.
I would love that.
one of 6 kids in the middle. None of my family is in a medical practice. I was, one of the things I want to, I'm going back to when I was a medical student. I felt very alone. There was very few Latinos in medicine, very few faculty mentors that you can see. And I think one of the things I want you to understand, especially what Dr. Hurtado and Dr. Parra already said, is that you already bring in skills. You have ability to speak to individuals or to patients that you connect with. I'm now an attending. I've been an associate professor, been here for more than 10 plus years. But I work with students and residents and fellows, and I always tell them, look, like you are your person. You are unique. You bring in your own life experience, your own life exposure. And I have multiple patients that I don't wear a white coat when I go to the clinic. I talk about when it's hot outside, take a shower, be in the tub, and the patient's like looking at me, like, how do you know this? And there's this connection that you have with patients that you may not see yourself that you have. And it's one of the reasons I'm up here is because I am able to take care of a patient population that I connect with, but I can actually take care of them and give them the care that they need in terms of Medicaid or insurance, what have you. And I think that communication, that ability to connect, you need to have, own it and, basically own who you are as a person. I grew up in a different time. I would say 20 years ago was a different time of training. I didn't speak Spanish outside. It wasn't something that you did, especially where I grew up. And, it is something that I'm very proud of, knowing another language. You bring in something that patients connecting to a translator, what have you, is not the same thing. So I want you to first own that, own the fact that you know Spanish, own the fact that what is your name, Osorio, not that I married it, because I've been told that by patients. So who you are as a person first. And understanding that communication and knowing exactly, you're seeing some things, because when I did my master's in public health, I actually did the urban and built environment. And I did my master's actually at Mount Sinai, and it was one of the things that was my project. And one of the unique things was how Mount Sinai is built, and how one side is really Fifth Avenue, and Fifth Avenue, anybody who's not from New York knows Fifth Avenue. And then the other side entry is from Madison, which is right across from projects and housing development, and how different the neighborhoods are just from one block ahead. So I just want to kind of bring in certain things. And in terms of how to manage common infections, so I am an internist first. I am infectious disease trained, but I'm an internist first. And I do inpatient and outpatient. So that's one of the unique things about infectious disease, is we're one of the few fields that still does both inpatient and outpatient. It allows you to be a primary care physician at the same time. So I think in terms of co-infections, I think it depends on the individual. If it's someone who's immunosuppressed, who has AIDS, not necessarily just HIV. If you're talking about something where they're having thrush or Candida in their throat, then yes, you can give them pills, give them solutions, what have you, nystatin or fluconazole. If you're talking about something where it's more of a CNS, like a brain infection, like toxoplasmosis, Cryptococcus meningitis, those situations, you really would want them to be admitted and to be monitored. And at that moment, we have an infectious disease consulting team here, not an HIV service, which some hospitals still do. And so we get consulted and we help with the management in that aspect. But it just depends, again, if there's someone that you're talking about that's immunosuppressed, and depending on the opportunistic infection that's present. And I think most people would say that anything that's like a CNS infection, I think that most people would feel more comfortable having the patient be admitted. But if it's someone or if it's a lung, depending on how symptomatic they are, if they're hypoxic, if their respiratory rate is really high, again, you would consider having them be admitted. But if we're talking about just thrush, then you may think that, okay, maybe this is just someone that can give them a pill. And if it's also someone that's just HIV alone and not immunosuppressed, but immunocompetent, or they're just having flu, those types of things we take care as an outpatient, common for most people who are immunocompetent. And I'll hand it over to Dr. Hurtado, Dr. Parra. But I just wanted to answer the communication, because that is something that I feel very strongly that all medical schools, residencies and fellowship really should do, because it's really about knowing where your patients are coming from. That's important, not where they're getting their care.
I really appreciate you chiming in that question. I think you provided such a great input and insight. Everyone really did. And I've been with you guys for 20 minutes, and I already feel so connected to each and every one of you, because we have such similar backgrounds and just similar passions in terms of providing care and quality care to our patients, and where we come from. And I really appreciate you chiming in, Dr. Osorio. And in terms of the clinical practice setting question, I think like you said, it is really specific to the patient. But I think another thing that I would like to add on is what you said about if the patient's immunocompetent and they have a flu or they have something else, you treat them like any other patient you would, right? And so I think we forget, sometimes you don't need to have any special considerations for patients with HIV and AIDS. Sometimes you do, if they are immunocompromised and have AIDS, then perhaps you do have to have some special considerations, and sometimes it's just not necessary. So I am going to skip over to the next question, which talks about research. And so I'm going to let whoever feels comfortable with this question kind of answer or, give us their thoughts. And the question is, what are the ethical considerations in HIV/AIDS research and treatment, specifically in vulnerable populations?
I can start with that question, and then others can chime in. So I do a fair amount of research in the field of HIV, and I would say that the ethical considerations are really, really vast. So, Fortunately, we have institutional review boards, which are created to review any research protocols before research is actually implemented in a community, in a population, in order to protect patients, so that back, it seems inconceivable, but we've all heard about Tuskegee and other studies. Those are in our lifetime. Those are people we know were affected by that, and so really important to protect vulnerable patients. And patients with HIV are one of the most vulnerable groups, along with children, prisoners, other vulnerable groups. And so you can think of the myriad of ways in which we need to protect our patients. And so, like, one of the first and most obvious reasons an IRB is needed for any research related to HIV is because anyone involved in that research automatically knows a patient's HIV status. If they are, reviewing records of, if they're doing a trial, which, for example, is only going to recruit patients who have HIV. And if they don't have an otherwise, clinically relevant need to know their HIV status, and you're exposing people who may be very private about their status. There's a lot of stigma still to this day, unfortunately, related to HIV. And so that's one of the first things that comes to mind is just accidental disclosure of status, or records are left, many things along those lines. But then there are even probably some of the most interesting ethical considerations that come up in HIV research. For example, one of the areas that a lot of research is being done in, that I'm hoping we're going to make really significant progress here in the next few years, is in the area of cure. And so, for example, in order to do a cure study, a patient's therapy needs to be interrupted. So we have really effective treatment now for HIV that makes it so that people with HIV can live, the life expectancy that nearly approximates those without HIV. But that's with taking antiretroviral therapy every single day without missing. And then in these cure studies, what we purposefully do is stop the treatment that's keeping their HIV from progressing in order to see if the cure works. And so that has significant consequences in terms of the potential progression of their disease, in terms of their potential transmission to others, because another huge advancement in the field of HIV is we now know that once a patient's on therapy and achieves virologic suppression, they can no longer at risk for transmitting the virus to others. But if we interrupt their therapy, that's not true anymore. So if they have sexual partners, they're then at risk for transmitting to others if they participate in the cure research. So I think it just brings up, and those are just two very brief examples. So I think it just brings up a lot of the different ethical considerations that can come up, and how important it is to think through all of the implications before proposing a study or recruiting patients to a study.
That was so interesting that you brought up not only the HIPAA related stuff, but also, like, we're trying to find a cure, but in the process, do no harm. And so at that point, those ethical considerations are so important. Does anyone else want to talk about ethical considerations?
I think I've been here in New York for 14 years. I think the thing that I try to very cautious with the residents and medical students is we talk about HIV because as it's a chronic disease, it's actually, something that you can live the same as anyone else. But I'm very mindful of stigma. Even in the middle of Harlem, when I see a patient in the floors in the inpatient side, I write HIV. I actually don't say it. I'll say, Dr. Gandhi, what you see Dr. Gandhi for, or what have you, and I let the patient disclose what they feel comfortable with. And the majority of times they don't want disclosure. And, we have rooms where they're sharing with someone else. So I think I'm glad to hear that Dr. Hurtado, stigma, I think, unfortunately, in 2024, even in the middle of Harlem in New York City, is still present. People would rather say that you have diabetes or cancer even out loud than to say that they have HIV. And being mindful of whatever context you're in, even international, that there are some places, like I was in South Africa as a fellow, and they use RVD, retroviral disease. And that's what they would say out loud. But the implications of disclosure for many people is their community, it's their family. And so I think that's one thing to be mindful of. I'm also, so I'm very involved in research, but it's about equity. So my equity talk would be just, be mindful of who's being recruited. When you are the researcher, when you have the grants, when you have the funding, who are the people that you're enrolling? So one of the projects that I worked on as a fellow was actually collaborating with San Isidro Health Center, which was like basically one exit from from the border. And that was because at UCSC, the Antiviral Research Center was in the middle of the city. It was also it was LGBT identified. It was Hillcrest. And my focus was acute and HIV infection in individuals who were men who reported sex with other men. But again, disclosure. And so we worked with this community clinic and we were able to do a project there. But again, it's access. Who are you enrolling? Are you enrolling everybody, including women, I would say? Are the resources eligible for, eligible meaning like, are people being able to understand what you're giving them in terms of informed consent? I don't like the word educated. When you say educated or even patient education, that implies that everybody has access to universities and colleges. And unfortunately, most people would say in many places, people don't have access to that. So my dad has all my degrees because really all the ability that I was able to go to multiple schools is really because of my parents and my family support. And it's really just the moral support that they've been able to give me, which is more than enough, I'd say, and even more. So it's about who you're enrolling and making sure you're enrolling everybody. And when you enroll, making sure that the resources you're providing are allowing people to get the information that they need to make an informed decision about being part of the study. I think, again, different time. I was the first COVID attending here at Morningside, very aware that we were doing multiple studies. I was actually involved with the remdesivir, the convalescent plasma studies as they were coming out. I was the only bilingual, one of the few, I say, investigators, and I made a point to work so that I can inform and consent people because I wanted everybody to have access to this remdesivir and convalescent plasma at that moment. And I think now there's more information about making sure that when you're getting preliminary data, do you have enough women? Do you have enough people who are considered underrepresented? And now many of the pharmaceutical and grant resources are actually saying, hey, what's going on here? You need to get more people that are this or that, depending on what it is. So that's kind of the cool thing about what's been going on with research now. But in terms of the ethical considerations, it's not just being aware of stigma for HIV, being aware of what Dr. Hurtado is saying, what's called the community viral load. When someone is off their medications, their viral load is going to get high because they're not on medications. And you may, be part of what's called transmission. And unfortunately, these are things that we provide the patients information so that they're aware. And then just making sure that you're equitable in what you're doing and making sure all patient populations, because what happens is whatever the studies find, this is how medications get approved. This is how insurances say that things are covered. But also you're not sure if the population that's actually being enrolled is actually, the question we always ask in evidence-based medicine is this population in the study reflecting of the community that you're serving? And a lot of times, not more so, but early on, I would say that wasn't the case. Now I think more awareness is allowing us to say, oh, maybe actually, yes, this is reflective of the patient population that we're serving. Maybe this is impacting the treatment or the decisions I make for this patient. So just kind of think of stigma, think of resources and equity every time you're thinking as a researcher, but I would say as a clinician too. But you see, I do both hats myself too.
I'm so glad you brought that up. I think equity is huge. And I agree that many people are working hard to make sure that the patients enrolled in trials are reflective of the community with that, with HIV, if it's an HIV trial. But so many of the data that we go on now is from studies that involve, for example, only men or a very homogenous white population. And so really important, especially I think as we're here with the NHMA. The one thing I haven't seen yet is I still see people turned away from studies because of language. And so even though, trials are working hard to have benchmarks for a certain number of non-white participants or, gender breakdown, I think we still turn away a lot of patients because of language. And so I think we as an NHMA community can be really aware of that and push for resources to make sure that, we diversify the field of providers and researchers so that we have more and more people who are bilingual, but also so that these tools can easily be made available in English and Spanish and other languages. And so really pushing for that to happen when you're working on a trial is important.
Absolutely. And I'm gonna pivot real quick to one of the questions that we have in the chat. If someone is asking, do you think mentioning that HIV/AIDS is treatable and manageable may affect the urgency of taking action by people at risk? Let me know your thoughts.
I can jump in first. I think it's a very valid question. And I think the way to put this is about patient autonomy and information. I think it's very important to let patients know the resources and access. And when we think of a chronic disease, we want to there's two angles of it. It's to say that it's manageable, it's treatable, but there is some data in terms of like the earlier we start medications, we are going to decrease inflammation. We're also going to decrease what we call the reservoir. So the virus can sometimes hide in the nervous system in specific areas. So we would really want to hit the virus as early as possible to decrease just the overall long-term consequences of the condition, not just from AIDS, but just from inflammation, which puts people at higher risk of cardiovascular disease and some other conditions. So that's one way to look at that. But the other way of why we want to say like there are terms like rapid initiation and trying to get people to treatment is from a community and social responsibility. If we get this person to be in treatment sooner, the chances of this person transmitting it to someone else go lower. So that's how we really try to present the information, and then also thinking of other resources. So when we think of HIV, just not just think about HIV isolated, but also some of my patients, I work at a FQAC that serves predominantly people who are on a stability house. So, yes, HIV might not be the priority right now because they are struggling to find shelter, how to eat, but just having those conversations, I can say, okay, let's maybe refer you to a food pantry. In New York, we have something called HASA, which can help patients get housing resources. Sometimes there are concerns that, we know what the housing units are, and it could be stigmatizing because you're in a building where predominantly people who have HIV live. So we have to kind of navigate all the systems. But the goal of really connecting and saying that is like, this is one part of you, but we want to address and work on the other elements. And that's why when we talk about HIV care, is primary care. And many patients are living a long, stable life with HIV. That is the least of their priorities. Sometimes it's really their diabetes, is their hypertension, is weight issues, and then the other social issues as food insecurity, access to shelter, and a number of other things. So that would be my approach to that question.
Thank you so much for that answer. I think like taking into consideration social determinants of health has become so much more common nowadays, and people are starting to take a little bit more awareness. But I think like we're still not there. We still have to continue to be very mindful and ask the right questions even during like our meetings with patients, and just be very conscious of also the efforts that we set forth to make sure that all these other issues can be tackled, and that food security, for example, can be addressed, and housing. And just because you have a house, does it have running water? Does it have, like all the things that we just kind of take for granted and assume that just because someone is housed, they will have all these other things as a part of that.
And I agree with all that. I would just add on just to also continue to address the initial question, that's a really good question. And it's a balance, I would say. I think we're lucky in that we don't see as much, early in the epidemic before we had effective treatment, where there was a lot more probably perceived urgency because so many people knew somebody who died of HIV or had become very sick from an opportunistic infection. And fortunately, we're really lucky that we don't see that as often anymore. So people may, and so perhaps it's true that, you know, emphasizing that it's a chronic condition that people can live. I think the first thing I tell people when I see a new patient with HIV is that to remind them that if they remember nothing else from that first visit, they can live a long, healthy life with HIV. But you're right, maybe that in some cases, if that's the message that we continue to give, that it might decrease the urgency of testing. And so it's that balance between, you can live a long, healthy life with HIV, but it means taking a medicine every single day. We don't yet have a cure. And so the balance between the real messaging versus the fear, you know, we don't want to instill fear in people that we live through that. And I already have to walk so many people off a ledge because they still, you know, they still come in with misconceptions about HIV and think that they're going to die of HIV. And so I think it's a balance, but I think your point is really well taken. And we don't want to generate complacency and make people think that it's not a big deal, and, you know, and then have them delay testing and linkage to care and things.
I wanted to, Dr. Hurtado remind me of one of my first patients living with HIV. And so one of the things is like us saying, you're going to live a long life. If people are struggling to make it from day to day, that's also like a message that doesn't matter, right? Like if I'm struggling to survive today, that is not important or relevant because I have to secure, am I going to sleep under the bridge or I'm going to be on the subway? So I think that is also important. My first patient of my HIV fellowship was a patient that was 27 years old, who had pretty advanced AIDS, was admitted for PCP pneumonia, and unfortunately did not make it. And so I think it's also important to kind of think of that we still have many young patients, that sort of that urgency and issues with access and stigma and racism and a number of other factors affect their health. And so sort of it's very important as we have in this conversation, and certainly we'll never forget his face and the story, to think that this was 2017, that we were losing a patient that was as young, and that was a failure of our system, of our society. And so that is important. We see them in the South Bronx, we see them in Harlem, we see them in many parts of the country, in the South too, very pronounced. So that's when it's like, it gets you upset. And sort of this is sort of balance between urgency and like, you can live a long life. We have to, you know, balance those two.
And I would like, oh, go ahead.
No, I was just gonna say the same thing. We just had someone less than 25 years of age, and I'm here in New York, and that died with AIDS complications. And it's, for me, it's a failure of the healthcare system, because at what point did their physician, when they were younger, not, number one, give them the conversation, do even testing, offer things like prevention, things that we have now, including, you know, not just pre-exposure prophylaxis, but here in New York, post-exposure prophylaxis. I do the hotline, which is 24/7 Elton John, and I do it to this day because it lets me see what's going on in the community and how there is lack of information of just how HIV is transmitted. You know, I get people that say I hugged someone, I kissed someone, and this is again 2024. So, you know, the need is there. We all agree that the need is there. And I appreciate the question. I also struggle with that question. You know, what is it that we can do better in terms of we don't want to be complacent. We also don't want to, you know, that's the first thing everyone thinks about. I'm going to die. No matter where you're from, everyone is going that route when you get told you get HIV. But then do we want to be complacent? But I think the middle ground is we just need to get people to be tested and to be informed of transmission risks and things like that, because I feel like that's not happening at a young age, or even as an adult, because I have people in their 50s who are calling me about these things. So I think that needs to be done first. And since 2006, the CDC has asked for universal testing, but yet I see many internists, pediatricians, family medicine, who do not test because they don't feel comfortable. What if that result comes back positive? But that is, again, a lack of us feeling comfortable, similar to what is, you know, we can go into the LGBT and hormone therapy, which is what I do, but that's, you know, a separate conversation, but similar. But that's what I want to kind of, I appreciate the question, but I think it's a middle ground. And you also have to be aware of where you're at. I'm in New York. The South is very different. Texas is very different. You know, even getting a test is very hard. So be mindful where you're at and what can you do where you're at to make things better. And is it as simple as just making a patient comfortable or for you to bring up the question about testing? Because I've had 60-year-old women ask me for an HIV test, and I used my own cognitive bias by not asking them. This was like 15 years ago. And so I'm just wanting to be mindful, just make it be something that is as easy, you know, something as checking your cholesterol should be asked, you know, or, you know, what about HIV testing? Because, and then just bringing up that conversation. But 2024, we're still having this conversation about comfort and testing.
I agree. Thank you so much for that input. Someone in the chat came up with a really great question, and it aligns a lot with one of the questions that we had prepared, which was essentially, as medical school graduates, as residents, what are some opportunities or for public health interventions, for research? For example, this resident, she is at Northwell at Phelps Hospital, and they were saying that there's opportunity to integrate more electives into their schedule, and wanted to see what you guys recommended, what type of experiences to support these career interests. They also wanted to hear a little bit more about like HIV specific fellowships that could be available out there. So if you guys could kind of talk to us a little bit about, you know, if what is out there.
Yeah. So I can start from the general primary care generalist and approach. So before doing the work that I did in community health, I was faculty at Einstein and Montefiore's family medicine. So I think we certainly need to push for HIV care to be part of the general curriculum of every single medical student of every single specialty. And so this is kind of what, you know, Dr. Osorio said. We need to feel comfortable asking and offering and the general. So I'll start. There is a number of tracks in medical school and in residency that help students feel more comfortable in HIV care. But that's not to say that it should not be part of the general training. So we're going to have a PowerPoint slide at the end that has some resources that you should check, or like what are things that medical students can look into and advocate for it to be part of your training in medical. So then there are residencies so I will focus on the primary care part within family medicine and internal medicine that have primary care specific tracks with HIV care. So certainly look at that. That means that you spend more hours with clinicians that spend more HIV care. There are more conference, there are more trainings. One of the things that I like to say, the place where I practice at a federally qualified health center primary care clinic, I see from the little kid to the 97-year-old lady to the patient living with HIV, with diabetes. They walk into my clinic, no one knows where they are working for, even though originally it was a HIV/AIDS organization. And I think this is important, that we want to create a message that HIV care and prevention is part of primary care. And certainly we want to reach out to our consultant specialists when it's more complex care, but we're all capable of doing that. The second part in terms of what is this post-fellowships, so there's different ways. I did it the primary care track, and there are two major ways. You can do specific fellowships through HIV/MA, which funds. There's also another one in Boston at Lawrence. There is one, I believe, in UCLA and UCSF and Montefiore. So there are specific one-year fellowships for HIV medicine. But that doesn't mean that if you don't do a fellowship, you will not get the training, because we understand the financial issues, responsibilities of more training and delay in starting a full-time job. There are different conferences. There's also preceptorships. Mount Sinai has one of them, but I'll let Dr. Osorio cover that one. There's the AIDS education training centers for each part of the country. So this is where we want to create this hunger for learning, your lifelong learnings. You can do virtual, you can do conference, you can do those things. And there's a number of support. There's even the National Consultation Hotline. I did it when I was at UCSF. There were patients from clinicians from the middle of nowhere calling us like, this is a patient, I have the basics, but I need your support. So you're not alone. And I wanted to put a plug about the financial issues. Financial health is important. Many of us do not come from generational wealth. So I'm the first one in my family to go to college, and I'm the first one to go to medical school. I have been doing the public service loan forgiveness, so I'm almost there with my 10 years, and hoping, so I want you to look into those things for loans that can be forgiven. There is a National Health Service Corps. I did that too, that they provide part of payment towards my loans so I could work in certain areas, and I work in those areas by choice. But there's also advocacy. We do know primary care is undercompensated, ID care is undercompensated, HIV care is even more undercompensated. Many ID specialists do not qualify for some of the loan forgiveness that primary care does. So this is something that the national organizations, IDSA, HIV, have been part of some of those advocacy that we keep asking for. But certainly, yes, you still have to take care of your family, of your loved ones, their resources, their opportunities. And if this is something that you want to do, there's always a way. So I'll stop there and pass it to my co-panelists.
I think that was fantastic. And I would just add to that. I know there's some links being shared at the end and in the chat, but the just from the HIV provider perspective, if you're a family medicine resident or primary care resident, we are always eager to have you rotate in our clinic because we are farther and farther behind from our internal medicine, for example, training. And so having somebody who's, in the thick of training and really good at hypertension management and diabetes management, which often my patients come here regularly for their HIV care, but they don't want to see another provider, and they're getting older and their management of their comorbidities is more and more complex, but many are hesitant to see outside providers. And so if you have an HIV clinic near you and you request to do an elective there, the providers there will be really happy to have you rotate with them because we'll learn from you as well.
And then this is the advocacy head. I think that was the thing from us too, is I am a part of the Rye White Medical Providers Coalition. I was a former chair. And so I work with the IDSA HIV-MA. We go to the Hill every year, and there's a different one. There's one that I'm just putting in, which is called the Help Act, but there's another one that is the Preparedness Workforce Pilot Program, which is another loan repayment. So these two are bills that are being introduced that are kind of in the midst of different processes of hopefully getting accepted in the future. But these are things that are being worked on just because these are things that all of us think about. And I myself have a product of two different low repayment programs, one being with a supplement that I got as a fellow with the NIH, which if you are an investigator, a junior investigator, you are available to get low repayment programs as an NIH grant investigator, which is one that I was able to get a lot of my loans paid for. Same thing goes. I was a part of the recent Biden, but more as a primary care, but also because I work in what's considered underserved area in Mount Sinai Morningside. Even though it's New York, it's still areas where it's underserved. And so I think just be aware that all of us think about these things, and there are things that even the people before you are fighting for people to get their bills, because I, as a medical student, got the primary care interest loan. And if you look at what I'm doing, it's mainly primary care. Yes, I do inpatient. I'm an ID consultant, but I do primary care in my clinic. And it's something that I argued at a Hill multiple times, because as soon as I did my ID fellowship, I got told, oh, you're doing a specialty. You're no longer able to you're not able to qualify. Now I was able to kind of make that work, but just be mindful that these are things that are being considered. In terms of opportunities, exactly what Dr. Hurtado and Dr. Parra said, a lot of us would want you. You can come to our clinics. I encourage the residents, the medical students to come to our clinics, because I think the part of the stigma is what people see is what's in the hospital. And that's when people are having opportunistic infections. That's when people are having really AIDS complications. And what people don't see is what's going on in the clinic. And I have patients, our clinic is similar to what Dr. Parra is saying. Our waiting area is mixed. It's not just HIV positive, it's also HIV negative. And so people don't really know who has what. And what you see is people that look like all of us who just happen to have HIV. And it really gives you to see that you really can know your patients, but you have this little mix. And one of our ID physicians is also integrated medicine trained. So she does integrated medicine, acupuncture, massage, nutrition. So there's so many opportunities in infectious disease, but in HIV care that I just want you to kind of highlight and not just think about what we see as a picture of what you think HIV AIDS. You know, yes, we're here because that's why I came in, is there was this vulnerable population that no one wanted to be able to take care of. And I was like, no, I'm holding your hand, I'm hugging you. And that's why I went into it. But I also like the idea that I was able to take care of people. My oldest HIV patients was in their 80s, and some of them are people that were born with HIV who are having their own kids. And I think you have, you know, it's a very different makeup than what you see. And you might be taught in medical school, because it could be that some of your own faculty may not have the exposures that we have. So you're welcome to come to any of our clinics, as I say, and I'll put the biopreparedness workforce pilot program, because I think some of the attendees will be future advocacy people in the Hill fighting for these things as well. And I'll hand it over to the panel.
Thank you so much. I really appreciate you guys, and also being so open to receiving people and training them, and advocacy is such key. It is key to making sure that we can continue to diversify this physician workforce and that we can continue to provide care to our patients. And I do want to be respectful of our panelists' times and of our attendees. And so I would love to thank our guest speakers for their time and expertise on today's topic, as well as our live audience for participating today. Thank you for your wonderful questions. A recording of today's discussion will be added to NHMA's YouTube page and website within a week. Please remember that resources on HIV prevention and treatment for both clinicians and patients are available for our membership and partners. These can also be found housed in our Health Hub, hispanichealth.info, as well as NHMA's website and the CDC Nexus site. The CDC now provides free self-test kits available as well to be delivered to your door at no additional cost. See the website and other resources below. And program coordinators will assist in basically, we're going to have HIV treatment materials available for you for this. We have them right here. Please follow all of our social media as well. We have nhmamd.org. Follow us on LinkedIn, on Facebook, on Instagram, wherever you like to engage in social media. And we are just very thankful to have you here, and we hope to see you again soon.